Good morning. Thank you for the introduction. You ask how did I get there. The main point of my presentation will be shared decision making, and not so much about my own history with it. Foremost, I'm a mother of 2 sons, and I joined the Geboortebeweging in 2012 after my first son was born. Because I encountered the limitations of our system. But it also made me have more interest in obstetric anesthesia. So I was already a resident anesthesiologist, and now I'm an anesthetist with special care for obstetric anesthesia. Being part of the Geboortebeweging brings me in a special position, because I do not only understand the system in which I also work, but I also hear all the stories from women, good stories, but mostly sad stories. And it makes me more considerate to the women who are giving birth, who are pregnant. I'd like to ask you a question first, because in the 2 former presentations we all heard things to get anesthesia's role in safer obstetrics, but why safer? Medical care is safe, otherwise it couldn't be practiced. Of course, there are probably things that could go better, but I'd like to shift the attention more to compassionate care, because there are enough protocols, maybe even too much, in order to make medical care safer, but sometimes we forget the basics of care. And if you hear complaints about obstetric care, a lot of them are about communication. To give an example of compassionate care, or a proposal for compassionate care, a lot of women feel lost in the ER. When their child is born, it will be checked out. Her partner will be with the child, but she's lying on the OR. Even if we do our best to be considerate, to be nice to them, it's different when they have someone familiar with them. So why not have another person in the OR with them? So dad or partner can be with a baby, and someone can be with mom, someone familiar. Or if it gets too crowded on the OR, why not swap persons? When the baby with the partner leaves, have someone else on the OR. Like I already said, I experienced the limitations to our system, and besides professionally, I never have encounters within the anesthesia. But the things I've missed most during my pregnancy and delivery, I think will also apply for the anesthesia. The limitations: who's on call? Outside the office hours, we have to deal with a person who's on call. In most hospitals, the medical specialists or residents or other care workers, well, maybe they have less affinity with obstetrics, or less affinity with working outside the office hours in general. Maybe you've made agreements up front, but is that the same person who's on call? If the person on call has other ideas, you have to conform to that. An example, if a woman wants general anesthesia for a C-section, if it comes to that, she starts out normally, but she ends up in the OR, and the anesthetist on call first refuses to give her general anesthesia because spinal anesthesia is safer. But it's in her file, only he didn't read her file. So when he was pointed out that there were agreements, he gave her general anesthesia, but it gives a lot of emotion if you think you've made agreements and the person you have to deal with doesn't honor them. Another point is the learning curve of residents. A lot of stories I hear are about residents, and in some hospitals, even the youngest residents are involved with the epidural anesthesia on the labor ward. Sometimes with direct supervision, sometimes without direct supervision. The stories I hear are about residents that try 2 or 3 times, getting a little bit mad or a little bit frustrated with the women because they won't listen, they won't sit still, they want to perform as safe as possible epidural anesthesia. But for the women, when they are at a point where they're exhausted, where they probably overwhelmed by the situation, they're not teasing you by moving when you ask them not to. They're at a point, a deep point where they're in a lot of pain but see no way out. Another point is communication. Also in a lot of stories I hear women talk about that it wasn't clear to them how certain procedures go or what was expected of them. This can partly be changed by informing women up front of how things work, so they have an idea before they get into labor. Because when you're in labor, a lot of things just go by you. One of the important points is that we want to be informed. We want to be informed about our choices. Specifically for anesthesia, the analgesia, the choices, but also choices within birthing process. Even if you think that there is no choice, we want to be informed. That means use your brain. This is an acronym women can use to make up their mind. What are the benefits of what is proposed? What are the risks? Are there any alternatives? And what does my intuition say? And what if we do nothing? What happens then? This can also be used to get an informed consent. But an informed consent works both ways. It also means a responsibility for us, for pregnant women. We need to prepare ourselves for what to come. Because how can we deliver a baby without knowing how the birthing process works? If we know what we need to create the best environment to give birth, the more likely we won't be overwhelmed by the process. So I think that every woman should be informed during a pregnancy about anesthetic possibilities and not at the point where she might need it. And it doesn't have to be a one-on-one talk, but group talks will work as well. I'd like to share a few thoughts from a lot of members of the Geboortebeweging. We want informed choices, just like I said. Informed choices starts probably with leaflets. Things we can read up front, we can talk over with other pregnant women on preoperative screening, or group talks with an anesthetist or other members of the anesthetist team. We like to be informed. What choices of anesthesia are there? What are the risks? What are the benefits? But also, a part of this is informed refusal. If we are informed the right way, just like I said, through brains, if we refuse things, it will be a well-informed refusal. Why not let women choose their own kind of anesthesia? If you have the right information for all the women, women can choose for themselves what they want. They're the ones who are going into labor who need the analgesia. But this can only work after be truly informed about all the risks from all the different analgesias. Walking epidurals was one of the questions I heard a lot from women. What's the difference in other countries? Why are women with epidurals strained to the bed? Why not be able to walk around more, more variations in the birthing positions? Why is there a big difference here versus other parts of the world? Be gentle. Communication during epidural, combined spinal epidural, or spinal anesthesia. The way we talk, the way people talk with women when they are in labor is sometimes horrible, and we understand that you have to do your jobs well, consider all the possible risks, but don't forget the position where those women are in. Another point, what's different through the hospitals here in Holland, where epidural anesthesia is performed. Is it on a recovery ward or on the labor ward? Transferring women from the labor ward in pain to the recovery ward, where there are also patients after surgery, so you have to be quiet, or you disturb other patients. Things like that are things to reconsider. Just like I mentioned before, compassion on the OR, the position the women are in after their child is born, but also the pediatric check. There are hospitals where the children are checked in a different room, so mom can't see her child right after birth, and sees, if she's lucky, sees her child a couple of minutes after that. Compassion on the recovery ward. No separation of mother and child. A lot of hospitals try that. If children are well, they can stay with mom. or come back as soon as possible, but also keep recovery time short. If the baby can't come to mom, let the mother go to the baby. Keep the recovery time short. Don't wait until spinal anesthesia has worn off completely, but if it starts to wear off, with good instructions, let her go back. The take-home message from the patient view is have compassion, communicate well, ensure an informed choice or refusal, and informed consent for everything you do. Thank you.
Marieke, thank you very, very much. I think it's very good to hear it from the perspective of the patient once, even if the patient is an anesthetist. Does everybody have, is there anyone who has a question?
Thank you for this. I think it's a very important topic, the shared decision making. I wonder, how good do we know what pregnant women want? Because this is your story, and I know from the Geboortebeweging, and I have an outpatient clinic for women outside the guidelines, want to deliver. But could you suggest something how we could know what women really want? Because there's not a good research on it. As far as I know, we really don't know what pregnant women want.
No. I also think that a lot of women don't know what they want. And that's the first point. Women need to prepare themselves on being pregnant and giving birth. So I think that's the first step, because if they prepare themselves, they will come with questions, with things they like, things they won't like, things they would discuss because they're off protocol. But I think it's starting with getting women prepared. Getting pregnant, giving birth is not just something you do overnight.
From my own experience, I think what women want is for their babies to be born safely. I've never met a woman who hasn't put her unborn child as at the center of, her expectations. I think you've pinpointed what, for me, remains the biggest challenge in maternity, which is about actually informing women, empowering them, and then letting them choose. Everyone goes on about sort of women's choice, but actually the subtext is often you can choose as long as you choose the option that I think is right for you. And I still see it today, whether it's, you can choose, but you must have a section because I think that's the best thing. Or you can choose, but, you must go for your normal delivery because that's the best thing. People are so evangelical. Let's believe in our women. I truly believe, given enough information, being empowered, they'll make the best choices for them. And they may not know what those choices are until it comes to the point, but then they'll make. Thank you.
Sorry for saying something again. What I would like to add to this, if women make informed choices, that should include also some realistic representation of giving birth. Some parts of birth care are too idealistic and wishful thinking, presenting that birth is a wondrous story, and the disappointment we experience daily when people come home halfway during delivery because they can't take any more the amount of pain and they need pain relief. So all participants, even if you are completely for completely physiological birth without any interference, be realistic and present realistic stories. And we from our sides, we should work more together with Geboortebeweging to present more realistic stories maybe.
Because right now some really strange thing, I read a birth plan not so long ago where the patient had written down, in case I need a C-section, I would like the room to be dark because otherwise my baby would. That's how realistic it sometimes can get.
No, that's true, yeah.
Oh, I agree with the previous speaker who said that the most important thing is for the delivery to be safe. It's safety above all else, because I myself experienced when my son was bradycardic for about 18 minutes and was just being prepared for C-section. But finally, he delivered normally, but later on he had soft signs. Later on, it was slow development and things like that. No? But that's where I think safety is of paramount importance in delivery. You want to make sure that baby is safe and well and doesn't have potential problems in the future. So I think that should guide. And who determines safety? You need to have the person with the most knowledge to be able to help. After that, you can make decisions about the accoutrements and all that. But the safety thing is the most important thing.
That's true. Safety is an important issue, but a woman is not just a vessel to carry around this child. You have to cut through the woman to get to the child. So you can in any emergency situation, you can always clear with the woman what you are willing to do, what the procedure will be. You don't need a lot of words for that.
Yeah, as you understand, I'm an obstetrician from Norway, and I totally agree that's about safety. And what, in my experience, it's sometimes that we as healthcare professionals have a tendency to focus even more on normal things than the patient, which was very interesting for me, because midwifery in Norway is very strong, and we have really good midwives and everything. And we discuss, for example, if we have some kind of screening, and if we have this information boards and the delivery wards where we write up risk factors, and all the midwives, they are screaming, no, we can't do that, because then the birth is not any longer normal, just if you put on a board, yeah, the woman had a cesarean section before. But if I discuss it with patients, all the patients say, yeah, of course, I'm so interested in that all the people being there know what I've been through, just to give them the best information, just to make my birth as safe as possible. And they don't understand how any midwives or how any other healthcare professional can say, yeah, we can't have a normal birth if we say that the patient is actually a risk patient. And so it's, of course, it's very important with communication, and to what I'm doing a lot is that I discuss with the patient, especially patients demanding cesarean section without any medical reason, and I often try to start with this. Yeah, at the end, I can give you not a guarantee, but nearly a guarantee that at the end of our talk, if you still think that the cesarean section is the best thing for you, I won't force you to do that, especially if it's breech presentation. And then we discuss it, and often I see the patient again after 2 weeks, so that she gets some time to think about it, and then I feel the patient has at least all the information, and she can decide what she feels is the safest thing for herself.
Being involved in some research about what women really want and what they expect about delivery, they want to have a safe or a healthy baby, and we want to have a healthy mother as well. But where we don't do it in a good way is the autonomy of women, because they want to be involved in the process of shared decision making. And as long as we do, and I think we can improve in that, because our maternal mortality and morbidity data and perinatal data are not bad.
My question is connected to the last question. Are there in any countries on a regular basis appointments with pregnant women and anesthesiologists? Because I think shared decision making always asks for a good talk together. And most of the time when we come to the patient, there is labor, there is pain, and that is not the surrounding of having a good talk and informing the patient. So is there in any country something that would support this?
Well, what I know, but that's more from my professional side, is that when women see anesthetists are when there is a planned cesarean, or if they know up front they want analgesia during birth, those women will go to the preoperative screening.
Medical problems.
Yeah, or with medical problems when they are discussed in a team, but that's more in tertiary centers, not in the smaller hospitals.